and we got an order, and it was for an exam that I did not know existed. I'd never seen before. The X-ray was for a soft tissue penis X-ray. Soft tissue penis X-ray. Yes, you heard that right. And we're like, a what? That's not an X-ray school. We don't learn that. That doesn't even exist. Well, apparently it was an exam that the doctors made up. But what happened was this elderly man came into the EC because he had almost severed his penis off. It was hanging by a thread. So we were getting the history, finding out what was going on. I saw every guy just cringe there, by the way. That was kind of funny to watch. But we get the history on this guy, and what happened was he was driving for a long distance, and he had to urinate extremely badly. But he was out in the middle of nowhere, so he had nowhere to go. I don't know why he didn't just drop off on the side of the road somewhere, but hey, that's his thing. So basically, he decided he was going to pee in a glass bottle. It was a glass Coke bottle, as a matter of fact. And as he was urinating in the bottle, he got stuck in the bottle. So instead of going straight to the emergency room, he decides he's going to fix this problem himself. So he goes to the nearest store, ends up being a Walmart that he stops at after driving a distance. He goes to the hardware area and gets a razor blade and attempts to cut the glass bottle off of himself using the razor blade. And long story short, he almost cut through his penis, except for a small part. It was almost completely severed. So that's when he rushes to the EC at Lake Charles, St. Patrick's Hospital to be specific, in Lake Charles, Louisiana. And they ordered the soft tissue penis X-ray. So we had to do a 2-view soft tissue penis X-ray on a cassette. And it did show up on the X-ray. You could see the injury, you could see the soft tissue, and they were able to evaluate the nature and the severity of the laceration. And as far as I know, they were able to reattach everything accordingly. And I believe his parts were working fine after that. But you never know what kind of X-ray you're going to get in the radiology department. Just because you don't learn it in Bontrager, just because you don't learn it in class, doesn't mean they're just going to not invent some X-ray. I got a lot more stories like that on... I got a lot more stories on some made-up X-rays I've had to do. I had someone ask me in the chat, what's the correct name for that projection? It just said a 2-view soft tissue penis. That's all it said on the order. 2-view soft tissue penis X-ray. Yeah. They made it.
So how did you perform that? I'm just curious.
I mean, we took the severed body part, well, almost severed body part. It was still attached. We placed it on the film. He stood at the end of the table, placed it on the film, and we did PA, I guess you could say, and then a cross-table lateral of the penis and got a 2-view X-ray. And we were able to see the nature of the laceration, that it was still repairable, and they saved his body parts in the end. Yes. So you never know what you're going to do in radiology. If you think you've seen it all, I guarantee you have not seen it all. There's always something new right around the corner. So that's that crazy story. I got even better ones than that. Don't worry. I always make a joke. I said I need to write a crazy X-ray story book and publish it because I've seen some stuff, man. I've seen some stuff. All right. I can't wait to tell you guys about the sunrise buttocks X-ray. That's a good one. The sunrise buttocks. That was a made-up one too. You can use your imagination there. Sunrise buttocks X-ray. I'll buy that book. Okay. I'll do some signings on Saturday. Come see me at Barnes & Noble. Yeah. All right. Let's go ahead and get the lesson pulled back up, guys. We're going to continue our wonderful journey into the wonderful world of lower extremities, and we're going to try to finish up the rest of this anatomy today and do a little bit of reviewing here as well. Let's get our PowerPoint pulled back up. All right. So we left off going over some of the anatomy on the foot. We're going to go ahead and review this a little bit before we get to the next area to make sure it's fresh on our minds. This is the same thing that we just went over last time. So let's go ahead and go through it together again to make sure that we are getting this anatomy down on these x-rays. First of all, what kind of x-ray are we looking at, guys? What is the view? What's the projection?
Lateral foot.
A lateral foot, you are correct. What is it pointing to? A is pointing to the larger of the two superimposed bones there, by the way. What would A be referring to?
Tibia.
The tibia. The tibia. What about, you know what, just so we don't all speak at the same time, I'm just going to go down the line here. So I'm just going to call on each of you. What is B, Aurora? What is B?
It starts with the C.
It does start with a C.
Calcaneus.
Calcaneus, you are correct. The calcaneus, very good. As Bede, what is C?
The left calcaneus tuberosity.
Oh, look at you being all specific. Yes, the left calcaneal tuberosity. Even though we don't see a left marker on there, we'll assume it's left. Left calcaneal tuberosity, very good. Amy, what would D be referring to? That is a tarsal bone.
That should be the it's the starts with a C.
Is that the talus? No.
It's not the talus. Starts with a C.
The cuboid?
Very good, the cuboid. You are correct, the cuboid. Okay, Daniel Cole, let's go to you. What is E referring to?
Tuberosity.
Of what?
Fifth bone?
Is that that's the left foot?
It is the left foot, but what's that tuberosity attached to specifically?
The fifth metatarsal?
Not sure. I'm not sure right now.
The fifth
the fifth metatarsal. Tuberosity of the fifth metatarsal on the left foot.
The tuberosity of the fifth metatarsal. And one thing to make note of, guys, because I did fail to mention this last time on Monday, the tuberosity of the fifth metatarsal is the most fractured bone in the foot. So if you remember back to the wrist, the scaphoid was the most fractured. In the foot, it's that that tuberosity on the fifth metatarsal is the most fractured bone on the foot. Very important point to remember. So Duyen, let's go to you. What would F be? Remember, there's a special circumstance on F when we're naming that.
I think superimposed cuneiform.
Very good. The superimposed cuneiform, or left superimposed cuneiforms. If you remember, on a lateral, all three cuneiforms are superimposed. Therefore, we can refer to them specifically as the superimposed cuneiforms. All right, Esaias, what about G?
Is that navicular?
Yep, navicular. Navicular, that arch, that rainbow-shaped bone. Okay. John, let's go to H, and H is referring to a joint. What would H be as in reference to a joint?
Calcaneal joint.
The talocalcaneal joint. Very good. Talocalcaneal joint. And Jaleisha, what would I be?
Is that the talus?
Very good. Very good. And who can say it first? What's the little hole there? Anybody?
Sinus tarsi.
Sinus tarsi. Good. Sinus tarsi. Very good. All right, let's go to our next view here. This is the one we left off on last time. So, Javier, we're going to you. What kind of projection are we looking at here on this X-ray?
Right.
In AP?
It is AP, but an AP what?
AP of the right foot.
The foot. What else? What's going on with the foot?
Is it oblique?
It's oblique. Yes,
oblique.
AP oblique foot. AP oblique foot. All right, let's get through these guys before we move on. Jesse, what is A? That's a joint that's pointing at. Can't hear you. Unmute.
IP.
Do the whole thing.
First, what is it? First joint. First digit of the first digit.
Okay.
Look, you know it's IP, okay? IP.
Do I know? Do I know?
First digit of the right foot.
The IP, yeah, the right IP of the first, or the IP of the first digit of the right foot. You can write either way. Do side. IP of that first digit, first phalange, however you want to write that. Or of the hallux, the IP of the hallux. You want to be real fancy. Okay, Jonathan, let's go to B. Someone's dropping a package in front of my house. It's always someone dropping off mail in front of my house. What is B?
That is the head of the proximal phalanx of the first digit.
So correct. So more so the body than the head. So
Body. Okay, gotcha.
Yeah, the body of the proximal phalanx of the first digits. All right, Jolie, how about C?
The droid MTB joint of the fourth digit.
The MTP of the first digit, you are correct. Or the right MTP of the first digit. Don't forget those sides. Okay, Wani, what about D specifically?
Head of the first metatarsal.
Head of the first metatarsal, very good. Sharon, what about E?
Body of the first metatarsal.
Very good. Luke, what about F?
Base of the first metatarsal.
Very good. Base of the first metatarsal. All right, Maricela, let's go to G. And on our oblique foot, there is a special circumstance for this particular bone we're pointing to. What would G be referring to? Let's see. Maricela,
The cuneiform.
So yes, it's two cuneiforms, and specifically it's going to be the medial and intermediate cuneiform superimposed. Because do remember, I think I told you guys to write that down on an oblique foot, the medial and intermediate cuneiforms superimpose, and then that lateral cuneiform is seen by itself. Regular AP foot will see all three cuneiforms separated. And of course, the lateral, all three are superimposed on top of each other. Okay, Naomi with H.
What letter did you say?
Letter H.
H is the navicular.
Yes, the navicular. Good. I'm gonna keep doing that hand motion so you guys don't forget that. It's gonna stick. It's gonna stick. Jonathan, did you have a question? I saw you for a second.
Yeah, I'm sorry. I was just going to ask for G, like on the medial oblique, can we just say superimposed cuneiforms, or do you want us to say superimposed medial and intermediate cuneiforms?
On this one specifically, I would like you to list both that are superimposed.
Okay.
Intermediate, yes.
Gotcha.
Good question. All right, Ruth, let's go to I. What is I, Ruth?
I is the talus.
Very good. Let's go to Pamela. What is J referring to, Pamela? That's a specific portion, a specific spot on that bone.
Is the tuberosity of the calcaneus of the right foot.
Very good. Tuberosity of the calcaneus of the right foot. Very good. Shibu, let's go to K. What would K be?
Well, that is intermediate cuneiform.
So it is a cuneiform. Which one? Not intermediate. There you go. Lateral cuneiform. Lateral cuneiform. Okay. Sun. Let's go to L. Sun. Sun. cuboid, very good. Stephanie, what about M?
It's the tuberosity of the fifth digit.
Very
in
good.
the right foot.
And remember, that's going to be the most fractured bone in the foot. All right, Tracy, what about M? M's referred to a joint.
The fifth MTP.
Correct. The fifth MTP. Can you mute? We can hear your papers or something there. If you can hear me, Wani, if you can hit mute. I can't get to the mute button here. There we go. Thank you. And let's go back to Amy. What would O be?
Body of the fifth.
It is the body, but of what?
It's not the metatarsal.
No, it's not the metatarsal. Remember, there's 3 sections.
Body of the proximal phalangeal of the right foot.
Proximal phalanx.
Okay.
Good. Very good. Very good. So how are we feeling on foot anatomy so far? Is it kind of clicking? Making sense? Getting there? Good. We're going to practice more as we move on. We're going to go to the ankle review here now. Some of this is some of the things we've already named. A few other new ones here. Let's see what we remember on our ankle anatomy. So Aurora, I'm going to go back to you. And we're going to name, well, first off, what are we looking at on this left image? I know we haven't really done positioning yet, but what do you think that is?
AP right angle.
Oh, okay.
Right. Oh, sorry.
I think Amy answered that for you, but
I'm sorry. I thought you were asking in general.
no, that's okay. That's okay. So this would be an AP ankle. This is a specific type of AP ankle. You guys remember I showed
Mortise
Mortise.
you the Mortise view. And how do we know that's a Mortise view?
The mortise is open.
The entire joint space is open without any superimposition right here. And we're going to review that more as we get into positioning. That's a very clear indication that this is what we call a Mortise view. Because if this was a normal AP, the fibula would actually be obstructing the joint on the lateral side. But we'll review that more on the positioning portion of all this. So Aurora, let's go to you again here. What would A be? Referring to a bone.
The fibula.
Very good. The fibula. And if you remember, guys, the fibula is always on the lateral side, once again. And the fibula is the thinner of the 2 bones. You tell a little fib. You don't want to tell a big lie, you tell a little lie. It's a little fib. And once again, I don't encourage lying, but it makes a great point on anatomy. So my wife would probably kill me. Don't be telling them to lie. Do you tell that to your kids? I'm like, no, I swear I don't say it to my kids. I don't encourage my kids to lie. They got to tell me the truth. Daniel, let's go to you. We're going to go to B here on the distal portion of the fibula. What do you think B is? Do you remember what we talked about? Can you hear? Oh, there you go.
I'm gonna go with the lateral malalis.
Close enough.
Right.
Malleolus, close enough. So that's the lateral malleolus. All right, Duyan, what would C be? And C is referring to that whole joint.
Mortise joint of
The Mortise joint. The Mortise joint. Correct. Okay. Esbede, what about D?
The talus.
The talus. Very good. Talus. So on those AP ankles, guys, it's one thing to keep in mind on AP ankles. The only tarsal bone you will ever clearly see, I mean, like really clearly see, is that talus right there. The other ones are going to be pretty much superimposed and out of focus. Okay, Asias, let's go to E. What would E be?
Is that medial malleolus?
Medial malleolus, very good. The medial malleolus. And let's see, John, what is F? F is going back a few chapters. It's something that we need to make sure we recognize.
Epiphyseal plate.
It's the epiphyseal growth plate.
Very good. You guys see that? The epiphyseal growth plate is located on the tibia, but also where else, guys? See it right here on the fibula? What's that tell us? This is a pediatric ankle. Pediatric ankle. That very clear line that we see. Okay, let's go to the next view on the right. Jaleisha, what view are we looking at? What projection?
Is that a lateral left ankle?
Very good. There's no left marker, but it's left, yes, so it'd be a left lateral ankle. So let's name our anatomy. Javier, let's start with the letter A. It's referring to the whole bone.
The right fibula.
Oh, there is a marker on there. What am I saying? There's a right on there. Yes. So the right fibula, correct. The right fibula. Okay. Jessley, what would B be?
The callus? Right callus.
The what?
Not callus, calcaneus. However you say that, calcaneus. You know what I mean.
I don't know. Correct me if I'm wrong, class. She keeps saying I know what she means, but
you know what I mean. Calcaneus. However you say that, but it's the right one. I don't know why I keep, but it's the calcaneus. It's.
I got her, calcaneus. I got her.
You know what I'm talking about. I just can't pronounce it.
The right calcaneus.
See?
I believe last time, I think on Monday, you said the callus as well.
I did. I don't know why I keep saying.
And yes, we do develop calluses on our feet and toes, but
I think that's why I keep saying callus.
The tarsal bone in the heel is the calcaneus. Do not write callus on your test. That would not be an acceptable answer. That's a little bit too different of a word. Calcaneus, not callus. Okay, Jolie, what is C?
Cuboid.
The cuboid, very good. The right cuboid. Jonathan, what about D?
The right tuberosity of the fifth metatarsal.
Correct. The right tuberosity of the fifth metatarsal. And we'll say it again so you don't forget. It's a big point. That's the most fractured bone in the foot. The most fractured bone in the foot. Remember, Mr. Donnie, he repeats his stuff. It's really important to put a big star on that. Just saying. Hint, hint, you know. Wani, what would E be?
Right navicular.
That's the right navicular. The right navicular. See, my goal is when you guys get to your registry, you're going to see a foot, and you're going to be like this, taking your test. You're going to go, navicular. And those people watching you take your test and be like, what is wrong with that person? What in the world are they doing? Are they doing some kind of hand signals over there? We got to disqualify them from their test. They can't take that test. No. That wouldn't happen. Let's go to F.
Hand signals during the board exam.
You can do whatever you want as long as you're not cheating. What is F, Sharon?
Right talus.
The right talus, very good. Luke, let's go to G. Now, G is referring to that hole right there, that little opening.
The right sinus tarsi.
Very good. Tarsi, the right sinus tarsi. And last but not least, what would H be? Maricela. That's a specific portion on that bone, by the way. Specific landmark. It's a really small one, but it is there.
What bone? The talus?
On H right here, it's on the tibia.
Is it the malleolus?
So it's not the malleolus.
Is it the tubercle? The anterior one?
Very good. Yes, it is the anterior tubercle of the tibia. And that's a case point when it comes to viewing that piece of anatomy. We're only going to see it on a lateral foot or lateral ankle. Because if we look at it from an AP, it's superimposed. We can't identify it. So we only see that anterior tubercle on the lateral views. It's that most anterior portion of that distal tibia.
Where is the malleolus in relation to the tubercle here?
Where's the malleolus? The lateral malleolus is right here, because there's our fibula. You see it? So this would be the lateral malleolus, right here. And then the medial malleolus would be superimposed upon itself right here. We're not going to see the malleoli on our laterals, not clearly at least. So as far as the malleoli go, only worry about labeling the malleoli on AP and oblique views. Lateral, it's superimposed. Very good. All right, we ready for some more, guys? I'm sad to say there is a lot more coming, but here we go. We're going to now move more proximal. We're going to move. That's okay. Whoever just messaged me, that's okay. Go ahead. Thank you for letting me know. As far as the tib-fib goes, guys, we have a lot more anatomy to name here. Now we're moving more proximal towards that femur. So I'm going to actually start on the proximal end here, and we're going to make our way up. I forgot I. Well, what is I? I think you know what I is. Did I really need to go over I?
I guess you kind of went over it with that last one, right? So it's the tibia, right?
Yeah, yes. You know, that's my trade. I just forget one letter, yes? It seems to be my trade this semester. I always forget at least one letter.
Yeah, I kind of thought you were just combining up, like, went over it with that. But H is the anterior tubercle, right?
Correct.
And we can't see the malleolus in this view. They're superimposed. Gotcha.
You are correct, yes. Okay, so let's hit this tibial anatomy there. I have everything listed on the left side of what you need to know, but we're also going to label it on this diagram, and we'll also be able to label this stuff on our x-rays as well. So let's start with the distal end. We, of course, have our two malleoli. We have our medial malleolus, which is once again located upon the tibia on the distal end. We also have the lateral malleolus on the distal end. Fibula. Does someone have a question? I thought I heard someone speak up. Okay, so right here where you see a circle, guys, we have two pieces of anatomy. So if you remember, when I'm asking you to label things, I'm going to ask you to label either a landmark or a joint. If I'm asking you to label a joint, the connection point here of the distal tibia and distal fibula is going to be our distal tibiofibular joint. It's a connection point of the fibula and the tibia on the distal end. If I ask you for a landmark, there is a tiny piece of anatomy here called the fibular notch of the tibia. That's where the fibula fits into the tibia and connects. So even though they're kind of synonymous with each other, they're two different pieces of anatomy. So if I ask for the joint, it's distal tibiofibular joint. If I ask for the landmark, that's the fibular notch of the tibia. So no difference between those two, depending on what I'm asking you to actually label there. And also, much like when we talked about the clavicles, how they had a sternal end and a acromial end, the tibia has two ends as well. We have the distal extremity, which refers to the distal end, and we have the proximal extremity by the knee, which refers to the proximal end. Very, very similar to how we talked about on those clavicles. Now, of course, the central portion of the tibia, much like most bones we've talked about, is going to be the body or the shaft. That also applies to the fibula, by the way, even though you don't see it labeled here. So if you want to write that in on your book, because this picture should be in your book, that's also the body and shaft of the fibula. Now, on our fibula, there's a very distinct line going down the entire fibula. I'm sorry, of the tibia, entire tibia. This very distinct line you see right here. It's what we call the anterior crest. And the reason it's called anterior crest, it's found on the anterior portion of the bone. It actually is an indentation that looks like a crest. The anterior crest is that very prominent line going down the entire surface, anterior surface of that tibia. Now moving more proximal, we have another joint. We have the connection of the fibula and the tibia on the proximal end. That's going to be what we call the proximal tibiofibular joint. Now, if you compare that to the distal, down here at the distal end, we had that fibular notch. There is no fibular notch on the proximal end. There's only the joint. So don't mix those up. We have the proximal tibiofibular joint, the distal tibiofibular joint, but right next to that distal tibiofibular joint is a fibular notch. And that would be the landmark on that distal end. So proximal tibiofibular joint up here on the proximal end. Then we have this very flat surface. This is a great piece of anatomy. I love to label this area of the tibia, by the way. This flat portion of the tibia goes by the name of articular facets, but I prefer to use the term tibial plateau. That's the more used term as far as that anatomy is concerned. So I would prefer if you label that as the tibial plateau, which you see here in parentheses, but you can use either name. They would both be acceptable. That's referring to the flat surface of the proximal end of that tibia, the tibial plateau. You think of a plateau in geography, a plateau refers to a flat piece of land. Same concept. It's the flat portion of that proximal end of the tibia. Now, in the center of that plateau, almost like a landscape here, guys. Here's your flat landscape, which is your plateau. You have two little hills, two little mountains in the middle. They're like two little spikes. That's going to be our intercondyloid eminence or intercondylar eminence. You can use both terms. You'll also see them referred to as tubercles, but the most common term would be the intercondylar eminence. Another very prominent piece of anatomy to make sure you master and know. That's another one that I and the registry like to label. Those two little spikes that we call the intercondylar eminence. And then on the lateral and medial side of that tibia, on the proximal ends, we have two condyles. Much like the epicondyles up in the elbow area, we have a medial condyle on the medial side. We have a lateral condyle on the lateral side. That lateral condyle is real close to that proximal tibiofibular joint. And then it's not labeled on your picture here, but I'll go ahead and let you write this in your book so you can see it on this AP view. The fibula has a head and a neck. I'm going to draw it for you. The head of the fibula is right here, where I'm putting that red circle. The neck of the fibula is right below it, where I'm putting this blue circle. Those are two pieces of anatomy you need to know as well. The head and neck of the fibula. That's located on the proximal end. And yes, all of this anatomy we can visualize on an X-ray. So as you can see so far, we're adding a lot more joints through this anatomy as well. And as we get to it, we're going to have to label those types of joints as well. We have to be able to identify the different joint types. So moving on here, we're going to be looking at the same anatomy. So we're going to be looking at a lateral view.
I have a question.
Yeah.
Back to the anterior view, on the fibula, there's like a line. Do we have to name that line or no?
It's about this right here?
Yes.
No, that does not have a label for it. No. We label the one on the tibia because it's a lot more prominent. The one on the fibula is almost invisible and can't be seen. So we're going to only worry about that anterior crest of the tibia.
You want us to also label the tibial tuberosity? That's on the list there.
The what? Tibial tuberosity?
Tibial tuberosity?
Oh. No, that shouldn't be there. My bad. That should not be there. Okay, so let's look on the lateral view, guys. I'm going to mark that off of here too. Okay, so this is looking at the tibia from a lateral view, tibia and the fibula. Now, don't worry about this angulation here. You don't need to know this. I mean, if you're interested, there it is, but we just need to make sure we know the anatomy. So starting from the top here, once again, if you remember that flat surface on the proximal end of the tibia, there's our tibial plateau once again, which you can visually see very well on an x-ray, tibial plateau. And you will notice what's missing from that. We don't see the intercondylar eminence anymore. Let me go back a slide. There's those two little spikes at the very top, the intercondylar eminence. When I go to a lateral, they disappear. We don't visualize them on a lateral view. We're only going to see the tibial plateau on a lateral. Now, here we go back to the fibula. And remember how I told you to label the head and the neck? There's the head and the neck. But we also add one more piece of anatomy on a lateral view only, by the way. We're going to add what we call the apex of the fibula. Apex is the very top of the fibula that fits into that proximal tibiofibular joint. Right here where I'm putting this blue line, that's going to be the apex. So we have an apex, a head, and a neck. But the apex will only be viewed on the lateral view of a tib-fib x-ray. And once again, that apex is referring to the very tip top of that fibula that fits into that proximal tibiofibular joint. Now, same thing here, guys, when we're talking about the mid portion of the tib and the fib, we have the shaft or the body. And then we can visualize only on a model, by the way. I know I told you on the x-ray we can't see this, but on a model, we can go ahead and label that lateral malleolus and that medial malleolus. Medial malleolus is on the tibia. Lateral malleolus is on the fibula. On x-rays, we would not be able to visualize those very well. It would be virtually invisible.
What about the anterior crest on the lateral view? Would we be able to see it on an x-ray?
This is it right here, but you're not going to see that on an x-ray.
Okay.
So you need to worry about that on an AP. And even on an AP, it's sometimes hard to visualize. It's only going to be on certain patients, depending on the level of detail you get on your x-ray. But if you do see it on an x-ray, it'll be a very prominent line going through that AP view. You'll very clearly see it. And this should not say styloid process. I'm sorry about that. So I should say apex of the fibula. I'll have to fix that before I send that to you. And I got wrist anatomy thrown in there. I don't know what I was thinking there. All right, so let us move on to the femur. We're going to go over some patella and femur anatomy. Now, if you do remember, when it comes to the femur, do make note once again, when we talk about the femur, that is the longest and strongest bone in the entire body. Longest and the strongest bone in the entire body. When we talk about the patella, patella has two features we need to make sure we know about it. First off, in location terms, the patella is located a half an inch above the knee joints. Half an inch above the knee joint, or half an inch superior to that knee joint. Also, big star on this, the patella is the largest sesamoid bone in the entire body. Yes, the patella is considered a sesamoid bone. So the patella is the largest sesamoid bone in the entire body. And this on the right is going to be our anterior view, as if we were looking at a femur in an AP view. Once again, you don't need to worry about these angulations. Don't worry about that. But we are going to add some anatomy here that I want to make sure you know well. We'll start at the very distal end here, though. So we first have what's called the patellar surface. Now, you can't really see the patellar surface on an AP, but make note, we will see this on a lateral and an actual patellar view. Patellar surface, also called the intercondylar sulcus, also called the trochlear groove, has three names, is where the patella fits into the femur in relation to it. Now, there's a little bit of space there because there's a synovial joint. It's a little indentation for that patella to fit into the femur. It's what we call the patellar surface. And we will visualize that a little better on a lateral when we move on to that here in a second. Now, right here, of course, we have our patella. The patella is superimposed on top of the distal end of that femur. Patella being that largest sesamoid bone in the entire body. The patella has two main parts we need to go ahead and label. We're going to label this a little further as we move on. But when we talk about the top of our patella, erase this, hang on. When we talk about the top of our patella, it's going to be a little backwards sounding. The top of the patella is the base of the patella, where I'm putting this arrow right here. That is the base of the patella, if you want to go ahead and write that in on your diagram. On the inferior portion, where it comes to a point, the inferior portion of the patella is the apex of the patella. Two distinct pieces of anatomy to make sure you know in relation to that patella. The superior top of it is the base. The bottom is the apex, or the inferior portion that comes to a point. Now, moving up the femur here, just like everything we've talked about thus far, the main mid portion is what? The body or the shaft of the femur. That does not change with most of our bones that we go over. Now, up here at the proximal end of the femur, we have two prominent pieces of anatomy, much like how the humerus on the proximal end had what? A greater and lesser tubercle. The femur has a greater and lesser trochanter. 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 The greater trochanter is this protrusion on the lateral side, where I'm putting this outline. This is our greater trochanter. The lesser trochanter is the smaller indentation on the medial side, right here. So greater trochanter, lesser trochanter. I don't know why my cursor keeps doing that, putting these weird lines on here. So greater and lesser trochanter on the proximal end of the femur. Now, in between both trochanters is another prominent piece of anatomy. There is a distinct line, and it's actually visualized even better on a radiograph. In between the greater and lesser trochanter is a line right here, where I'm drawing this blue line. This is what we call the intertrochanteric crest. The intertrochanteric crest. Another prominent piece of anatomy to make sure you know. You write that in on your diagrams.
You said intertrochanter crest?
Intertrochanteric crest. I don't know if you can read my handwriting, but no, it's not going to let me write it. But intertrochanteric crest. Intertrochanteric crest. Now we have a thin portion here, guys. Based on what we've talked about with a lot of our bones, what do you think that is? Anybody tell me? This thin portion right here.
The neck.
The neck, the femoral neck or neck of the femur. And then, of course, what do you think the round part here would be fitting in that hip joint?
The head.
Based on all the anatomy?
The head of the femur?
The head of the femur, very good. The head of the femur. Now, you will see this is already labeled as a hip joint. I want you to go ahead and write something next to that, because one of my favorite pieces of anatomy is that hip joint right there. It goes by another name called the acetabulum. But you guys have heard me talk about that already, the acetabulum. You do want to use the word acetabulum when referring to that hip joint. Acetabulum. ACETABULUM. And then when we get to the pelvis, we'll label more of this pelvic anatomy, but right now we're just focused on this femur. So here we go. This is going to be the posterior view of the exact same thing we talked about. We're looking at it from the back now. A lot of this is the same things we just named. We have the greater trochanter on the lateral side, the lesser trochanter on the medial side, that fin portion that we call the neck, and that round portion that we call the head. Now I'm going to add one more here, guys, because this is visible on some of our x-rays. A little hard to see, but can you see the little hole on the head of that femur? There's a little hole right here. See that? That's what we call the fovea capitis. F-O-V-E-A, capitis, C-A-P-I-T-U-S. Fovea capitis. We can visualize that on some of our x-rays, so make sure you know what that is. It's a little hole right on top of the head of the femur. Fovea capitis. Now moving more distally, we're going back down here. The mid portion is what? The body or the shaft. Now, there's a surface right behind the distal portion of that femur. It's a flat surface that we call the popliteal surface. That's an important one to know right there. Popliteal surface is the flat surface on the back of that femur on the distal end. If you were to go straight through this femur, if we were looking straight through it, the patella would be right here, guys. So that's our popliteal surface. Then on our femur, we have a medial epicondyle and a lateral epicondyle, much like the humerus had. But also we have a medial condyle and lateral condyle. Now this is where it gets a little confusing. So go back to the distal portion here. The medial epicondyle is this portion of the distal femur. The lateral epicondyle is this portion of the distal femur. We use a different color here. Where I'm putting the red is the medial condyle. It looks almost like a big circle on an x-ray. And then we have a lateral condyle. Don't mix these up. They're very similar words. The smaller one that's on top here is the epicondyles. Right below both those epicondyles are two condyles. And the condyles are much more prominent, especially when we visualize them on our x-rays. And I'll show you what we mean on the x-rays when we get to it in just a second here.
Mr. Donahue, on the test, do you want us to write medial epicondyle of the femur? You want us to be that specific?
Yes.
Just making sure. Thank you.
And why do you think that is, Betty? Where else do we have epicondyles?
In the humerus.
In the humerus. So we gotta make sure we know which epicondyles we're referring to. Yes. Okay. Now another prominent piece of anatomy, guys, in between both of our condyles is an indentation or a hole here that we're going to call the intercondylar fossa. Intercondylar fossa. Now you will see this one right here, guys. It says adductor tubercle. You do not need to worry about that one. It's virtually invisible on an x-ray. That's where the adductor muscles connect to, if you want to know. Everything else we've named, yes, you do need to know. Okay, y'all hanging in there, guys? I know it's a lot. Take a 5-minute break. I need to get me a drink of water. We'll take a 5-minute break and we'll pick back up on the new year. Let's meet back at 2:05. So it's 7 minutes. 2:05.
Yes. Yes, honey.
Are you in class?
Yes.
Can I see you?
Yes. What you need?
I feel like I'm not being important.
You isn't it?
I'll be leaving now. I'll be leaving now.
I have class for about 30 more minutes and then I'll be done, okay?
Okay.
Yes, sweetie. What are you doing here?
I want to say goodbye.
No. Sim is annoying.
Naomi, you cold too? I got my hoodie on too.
I'm telling you, it's so cold.
But this weather is so perfect.
Perfect for what?
Absolutely. Feeling cozy, but need the hoodie, you know?
I don't have a hoodie on.
What's your hoodie say? What university of what?
Houston, of course.
Distal, nice. I mean, I can't believe no one's commented on mine. You know, I got all these Avengers themed PowerPoints, and no one's going to comment on my Avengers hoodie. I mean, come on. I mean, right?
I never noticed. And then usually your PowerPoints are Lord of the Rings themed. So,
Now don't spoil it, Tracy. That's for next semester.
Wait, I thought, what did you do it this semester too? You had it this semester.
Oh, no, it's not to the next semester.
Who's your favorite Avenger?
Huh?
Who's your favorite Avenger?
My favorite Avenger?
Yeah.
It's a toss-up between Iron Man and Spider-Man.
Iron Man is the way to go. I'm just saying.
I agree with Naomi. We are on time.
I don't know what Jessley's talking about. You're in a different, daylight savings time's not till Sunday now. Jessley, I'm sorry. I don't know what you're talking about.
Mr. Donahue, I have a question about the femur anterior view. You said that for the lateral view, they said that this is the only projection where the patella is seen, or is it also seen in the anterior one?
No, patella is seen on the anterior view, but it's superimposed on top of the femur, so it's a little bit harder to make out, but you can still visualize it. And you'll see when we get to the x-rays.
Okay, thank you.
But you will get a clearer view of the patella on a lateral view, which we see right here. That's what we're going to. So here is a lateral view of the patella, femur, and tib fib. So right here, we have our femur in a lateral position. We have our tib fib in a lateral position, but we also have our patella in a lateral position. We're going to name some of this anatomy here because there's some anatomy missing on this picture. Go ahead and add it in on your diagrams if you wish to. But here's that popliteal surface once again. That flat surface on that posterior portion of the femur, which we can visualize directly on a lateral view. By the way, this popliteal surface will only be visualized on a lateral x-ray of the near femur. That is the popliteal surface. On the anterior side of the distal femur is the patellar surface. And that's that area where if the patella didn't have the joint space, it would actually fit into the actual femur right there. But there is a little bit of a space there to contain that synovial fluid for that synovial joint. And there's our patella once again, which is our largest sesamoid bone. If you remember, the very top of our patella, once again, is the base. The bottom of our patella, where it comes to a point, is going to be our apex. Base on top, apex on bottom. It's a little different than the lungs. I don't want you to mix that up because lungs have an apex and base. Kind of reverses from that. Top of the patella is the base. Bottom is the apex. And we'll say that a million times because I swear someone's going to write that in reverse. Top is the base. Bottom is the apex. I mean, put it in big, big letters if you have to. Now, once again, that flat surface. Who remembers what that flat surface on the tibia was called? Thinking about landscape, geography, what was that called?
Plateau.
The tibial plateau. Tibial plateau. Who could tell me what this joint right here was on the proximal end?
The proximal tibular fibular joint. Right?
Yes, the proximal tibiofibular joint. And there were 3 divisions on the proximal portion of the fibula. What was the most superior portion of the fibula called that fits right there in the joint? Remember?
Apex.
Very good. The apex. Right below the apex, the rounded portion would be the head. Right below the head would be the neck. Yes, the neck. Now, right here on the right side, this is what a sunrise view of the patella would look like on an x-ray. We do a specialized view of the patella. Some of you may have seen this in clinic that we call a sunrise view. It allows us to see that patella from an inferior view, and we'll be able to see that nice joint space between the femur and the patella. So this joint space right here, guys, is a very important joint that we need to make sure we label. We can see it on the lateral as well. It's not on your diagram, but you can write it in. That space between the patella and the femur is our patellofemoral joint. Patellofemoral joint. Very important joint to make sure you remember there. And then looking at the rest of this anatomy, and we'll see this on our sunrise view x-ray radiographs, we do have our medial and lateral epicondyles. Right below those epicondyles in that main rounded portion are our medial and lateral condyles. And then this actual indentation is that intercondylar fossa or notch. Not to be confused with that popliteal surface. The actual indentation would be the intercondylar fossa or notch. So one clue there, since those two pieces of anatomy are very close together, when we're talking about the fossa and the popliteal surface, the popliteal surface will only be visualized on a lateral. The intercondylar fossa will only be visualized on an AP or sunrise view. And we'll talk more about that on the positioning aspect. So you won't see the popliteal surface on an AP or sunrise view. You won't see the fossa on a lateral view. You'll only see that popliteal surface. So they kind of work inverse to each other there. And that space right there, guys, on the anterior portion of the femur, once again, here's that patella surface from the lateral view. When I'm looking up at it in a sunrise view, here's that same patellar surface that goes by these three names: patellar surface, intercondylar sulcus, or trochlear groove. I say stick with patellar surface. That's the easiest one to remember. All three of those would be correct.
Can you say that again about the what you were saying about the fossa and the popliteal surface?
Absolutely. So the popliteal surface and the intercondylar fossa are actually very close to each other. Let me show you what I'm talking about. Back on this posterior view, here's that popliteal surface, and then there's the intercondylar fossa. They're very, very close to each other. Now, when we're looking at this on an X-ray, we're only going to see the fossa on an AP or PA view of the femur. In this view right here, we would only see the fossa. We would not see the popliteal surface. But if I take an X-ray of the femur or knee in a lateral view, I will see the popliteal surface and the fossa disappears. So you see what I mean about it's a little bit inverse of each other? Just depending on what view, we're only going to see one of those pieces of anatomy. So make sure you know which ones we're looking at. Did I answer your question, Jonathan? Yes?
Yeah, you said you can see it on an AP and a PA view, the fossa?
Yeah, because on an X-ray, it becomes a lot more prominent. You won't see it on the models, but on an X-ray, yes.
Okay. Gotcha.
Okay, here's that patella once again, guys, just to make sure we hammer this home. When we talk about the top or superior portion of that patella, that is the base. When we talk about the inferior or bottom of that patella, that is the apex, where it comes to a nice point. Now, the patella does have two surfaces as well. When we're talking about the front of the patella, that's our anterior surface. When we talk about the back of the patella, that's our posterior surface. Now, they do have two distinctions as well. The posterior surface is considered smooth. That's about how it feels if you were to actually feel that bone. The anterior surface of the patella is what we call a rough surface. Rough versus smooth. The back is smooth, the front is rough. Top is the base, bottom is the apex. And that is, once again, the largest sesamoid bone found in the human body. Okay, so right here we have a few of our ligaments that we need to know. Now, you're probably looking at that diagram like, oh my God, not more. So this just to show you where they're located. I don't need you to label these. Yay, we should be saying yay. I don't need you to actually label these, but I need you to know that there are four major ligaments found within the knee. Do know them by name. Don't worry about labeling them yet. You'll do that a year from now. The seniors are doing this right now with me in Rad Pro 4. They're having to label all these ligaments because we're studying arthrograms. So you got a little bit of a break before you got to learn those. So for now, what I want you guys to know is the four major ligaments found in the knee joint. The knee joint specifically are the posterior cruciate, anterior cruciate, fibular, collateral, and tibial collateral. Know them by name. Don't have to worry about labeling them yet. Four major ligaments found in the knee joint. And of course,
can we go with the acronyms?
Sorry?
Can we just go with the acronyms?
If you choose to, yes. PCL,
Okay.
ACL, that's fine. Yes. LCL and TCL. And this is just showing you what that all looks like on a nice model. Once again, you don't need to actually know this model and put that in there for your own reference. If you're curious where all these ligaments are located, well, there they are. There's that anterior cruciate, posterior cruciate, named for their location in relation to the femur. Anterior, of course, will be located on the anterior surface. Posterior on the posterior surface. There's our condyles we just talked about. And we have also what's called a medial and lateral meniscus found in the knee. But you don't need to know those quite yet. Once again, that's when we get to Rad Pro 4. Keep it in mind. Don't worry about memorizing it yet. But just keep in mind, those are some major areas of the knee that we're going to get into when we talk about arthrography in Rad Pro 4. That's just showing you a little bit of it one more time here. Also, if you're curious how that synovial joint is located on the knee, we look here on the right on this lateral view of the knee. We have a nice, beautiful synovial joint capsule. When we talk about the knee being a synovial joint, that joint itself is actually quite large. That synovial joint is right here, going behind the patella, in between the tib, in between the femur, behind the femur, and in the front. Where I put all this red, that's that synovial joint that's found in the knee. And when we do what's called an arthrogram, if any of you have done an arthrogram yet at the hospital, you're actually going to put a needle in the patient's knee at that joint space and draw fluid out to do an analysis, because if the joint fluid is low, of course that joint's not going to function properly. They're also going to evaluate the integrity of that joint space, because some people get degradation in their joints, and as that joint space begins to deteriorate, those bones will actually begin to rub up against each other. So the patella would be rubbing up against the femur would be rubbing up against the patella, and that can actually erode the bones away, and the person would not be able to bend their knees properly. Happens to a lot of our older patients. But we'll get more into details on that on arthrography. I just want to show you that in case you were curious about it. Don't have to study these diagrams. Don't have to study these diagrams yet. A year from now, yes, when you're in the senior's shoes, we'll study these. And that's what an arthrogram would look like, by the way, guys. If you want to see what this looks like on X-ray, right here is that synovial joint, once again, that I just outlined on the previous picture. This is all the synovial knee joints, also known as a bicondylar joints. This is all filled with fluid. This is all filled with synovial fluid. That's how we are able to bend our knees. And you'll notice on the picture there, we got some white stuff. They're going to inject contrast in those joints to evaluate the integrity of those joints and make sure they're functioning properly. So that'll be a knee arthrogram. We'll study more of those next year. Okay, let's start reviewing what we just went over here. Let's see how we do. All right, who am I going to pick on here? Who am I going to pick on? I forget who I left off with, so I'm just going to start at the top again. All right, Amy, let's let you start us off. Your name starts with an A. We're going to start with the letter A. What is A referring to, Amy, on this tibia? It's okay. I know it was a lot we just went over. See how you do.
Is it the medial condyle?
You are correct. The medial condyle of the tibia. If that's, let's say this is the left, by the way, that'd be the left medial condyle of the tibia. That's on the medial side. Okay. Aurora, let us go to B. What is B?
The left tibia? Or
left
the body?
Left body of the
tibia. Left tibia.
Left body of the tibia. Now, you will notice, guys, remember how we talked about that crest? We can't really make it out on this X-ray. This X-ray does not have a lot of fine detail, but if we saw the anterior crest, we can barely see it right here. There's a little line right here where we can barely make out. It would actually stretch all the way down, and we would see that line very predominantly. Now, I won't ask you to label that unless we actually clearly see it on the X-ray. I'm not going to point right here and be like, oh, tell me that's the anterior crest. No, you can't see it. If I ask you to label that anterior crest, then it'll actually be predominant on the X-ray.
Mr. Donahue, how do you know that's a left leg and not a right? Because on the book they have it as
It's right. I missed the marker. I didn't see the marker on there. Anytime the marker's missing, I always just say assume for left. But I just noticed the marker there. It's a right. My bad. My bad. I was thinking that was a letter pointing at something. Okay, let's go to C. Duyan, what is C?
The medial malleolus, is that what you say?
The medial malleolus, the right medial malleolus of the tibia. Esbere, what is D?
the right lateral malleus.
Correct. Right lateral malleolus of the fibula. Asias, what would E be? You need to unmute, Asias.
The shaft of fibula.
The shaft of the fibula. The right shaft of the fibula. By the way, the right shaft of the fibula. Now here we're going to go to the top of the fibula. We got those three distinct parts once again. Let's go to John. What would F be?
Neck, right fibula.
The neck of the right fibula, correct. Jaleisha, G. I'm sorry, John, what?
Just like a pet peeve. Say right, like right shaft of fibula. In my mind, I makes it sound like there's a right and a left shaft. Versus, you know what I'm saying?
I mean, you can do it either way. You could say right shaft of fibula, or you can say shaft of right fibula. Both will be acceptable for me. I just want to make sure you're putting the side. Both I will accept. Okay, Jaleisha, what would G be?
Is G the right head of the fibula?
Correct. Head of the fibula. Javier, what about H? H is referring to the very top of that fibula.
Not the apex?
As the apex of the fibula. Apex of the fibula, good. All right, Jessley, what would I be? It's referring to this part right here.
The right lateral condyle.
Correct, the right lateral condyle of the
what?
Of what bone?
Oh. That's the tibia. No, that's the tibia?
Yes, the tibia. The tibia, yes. Okay. Jolie, what about J? J's referring to these two little spikes here.
No, tibial spine.
You said the tibial spine?
Yes.
Not tibial spine. Not tibial spine. Not again, or someone can help her out.
It's eminence, but in the book it says it as tibial spine.
Oh, does it say tibial spine in your book?
Yeah.
Okay, I'm used to calling it intercondylar eminence. So
it says eminence on the model on 218.
Okay.
Figure 6.17, eminence. Where would the spine be in this image?
Tibial spine and intercondylar eminence are synonymous. That's my text. Tibial spine and intercondylar eminence are synonymous names. You can use either one. I don't think I mentioned that earlier. I prefer you say intercondylar eminence, though. That's the more correct term on that anatomy. But tibial spine does work. If you choose to say tibial spine, you would not get that wrong. Do you have a question, Jessley? You're raising your arm. Yes.
Okay, so for H in my book, it's an apex, then parentheses, styloid process of the head.
Yeah, don't say styloid process of the head. Don't say styloid process of the head. Only refer to that as the apex of the fibula. So Jay, once again, guys, you can say tibial spine. I would prefer if you referred to that as the intercondylar eminence, though. Both would be correct. Okay, so this is not labeled, but I'm going to ask anyway. What's this flat surface on the tibia called? Jonathan.
Right tibial plateau.
Right tibial plateau. Very good. Very good. And we are going to stop there today, guys, because I didn't realize what time it was. We're about out of time. So we're getting close to the end of the anatomy on this chapter. Yay, thank God, right? Thank God. We've hit the end of the anatomy. We're going to keep reviewing anatomy. I'll check that out, Amy. Thank you, in the book. On Friday, bring your Play-Doh. We're going to do our competition on Friday on a certain piece of anatomy. I'm not going to tell you what it is yet, but bring your Play-Doh for that on Friday. And we will continue reviewing our anatomy, get into joints, and make sure we have a good, firm grip on this anatomy before we move on to the positioning portion, which will be going over a lot of positions as well. There's almost just as many positions as anatomy that we have to hit in this chapter. So on Friday as well, I have offered tutoring from 7 to 8. If you feel that this anatomy is giving you a lot of trouble, you feel like you're a little bit behind, you need that little bit extra focus on anatomy, I encourage you to come on Friday. Send me an email if you'd like to come to tutoring on Friday. A few of you have already reached out to me, but I'm going to do that from 7 to 8 on Friday morning, and we're going to focus primarily on the anatomy of this chapter. So please let me know if you're interested in that. A few of you I'm already meeting with, but anybody else that wants to, please let me know. Are there any other questions based on what we went over today? All right, guys. Well, enjoy the rest of your afternoon. Stay warm. It's going to get down to the 40s tonight, so turn your heaters on. Might be the only time we do that this year, depending on if it heats back up again. Enjoy yourselves, and I will see you guys on Friday. Have a good one.